all the delegates. Thanks for joining in. Looking forward to more delegates joining in today for the webinar. We are on a mission to reduce the cesarean section rate. A CS audit is being in process by the Ministry of Health and Family Welfare. But whatsoever the elective or the emergency cesareans, how to make them more safe, the target is today for this session. I would request Dr. Sharda Jan ma'am, who is fondly known as teacher of teachers, mentors of many of our students and colleagues, a great gynecologist, who has been a passionate medical activist and given the concept of Janani Suraksha Yojana and Asha worker. I welcome you, ma'am, to please give few words of wisdom on this topic of making cesarean section safer. Over to you, ma'am.
Thank you very much, madam. I remember that I passed out my MD in 1973. It is going to be 50 years today. So in the last 50 years, I have seen a lot of changes as far as cesarean section is concerned. The place I was trained is PGI Chandigarh, and that time during my training time, the cesarean section rate was 10%, and now it stands at 40%. And then I moved on to Lady Hardinge Medical College. That time when I left, there was 20% cesarean section rate, and at one given time, 4 patients for cesarean section on the waiting list. So that was the kind of waiting list because we had only one OT. Now, what I have seen, the changes is that, at that particular time, the admission was for 7 days, the antibiotics were going on for 7 days, that's the kind of, changes we have seen over the period of time. Things have become much, much safer because of the better anesthesia, better antibiotics and things like that. Thanks to Dr. Jyotsna, I was introduced to IRAS 3 years back, when we were making critical care course for gynecologists. At that time, I read it in detail, and there was one particular module was just dedicated to this, making cesarean section safer. So I think, what thrills me is that, the antibiotics are off now, you just give one prophylactic antibiotic in the golden hour and the job is done. And the majority of our cases are elective cesarean section. Emergency cases now, at this age of mine, I don't see emergency cesarean section. But another thing which is thrilling is that, previously, at the time of discharge, some of the people used to succumb because of the pulmonary embolism and things like that. And now this thromboprophylaxis has come in a very big way. And I think, more and more gynecologists have to rope in and use this particular practice during cesarean section as well, especially when people are with obese and with comorbidities. Otherwise, I'm not going to say anything today because, IRAS is, they're going to unfold. Things have become much easier now. Less fasting time and early, giving up the fluids and things like that has made a hell of a difference. The only thing I wish to just tell. I'm disturbed about the Percrita cases. In these 50 years of experience, many patients have come back to us. We have never found patients operated by us have Percrita. So I think, there's something to be looked into it. What is it? Is emergency, not supervised by the seniors, whether it's a single stitch flare is going on. What is the cause? This is very disturbing. And second thing I just wish to tell that there had been 2 cases in the NMC, National Medical Council, that the patient had atraumatic spinal anesthesia. No mention in the files, in both the files, there was no mention that it was a traumatic, but the lady developed signs of paraplegia 4 to 6 hours later when the doctors came for the round overnight, and they found that, she was not moving her legs. By the time they got MRI and things like that, it is already past 12 hours. And in case if the recovery has to take place, it has to be, diagnosis has to be made within 8 hours, and the surgery has to be done within 8 hours to have a complete recovery. So I think this is something, we need to see it, and, how we publicize this particular information, that this small thing should not be missed. After 4 hours, the nurses must call you back that, she's moving her legs. So I think, these are the 2 remarks which I wanted to make. And I think I wish this particular seminar a great success. And we definitely wish that cesarean section should really become safer. So thank you very much.
Thank you, ma'am. Thank you, Dr. Shada Jain, ma'am, for sparing time for us and motivating us and giving us some food for thought. Really, what you were saying about the paraplegia cases is something which really scares me, because we don't normally go and ask whether the patient is moving her legs or not, because we leave it to the anesthetist. So I think we need to be more vigilant on this. That is pretty scary.
Anybody who admits the case has a fault. So this particular fault comes at you. Why did you not diagnose? That's it.
Thank you so much, ma'am. Thank you so much, Shada Jain, ma'am. Thank you, Dr. Renu Mishra, ma'am. I would request Dr. Renu Mishra, our President DGFS, to please say a few words and introduce everyone to the webinar today.
Thank you very much. Thank you, Pancham. It's a great privilege to be hosting this webinar along with the rest of my DGF chapters of Delhi on Caesarean section. So modern obstetrics, you cannot imagine it does not exist without Caesarean section. As Dr. Jain said that earlier, this Caesarean section rate should be 10%, used to be 10%. If you look at the WHO, then WHO says that this Caesarean section rate, if it is exceeding 15%, then it is neither beneficial to the mother nor to the baby. But then there is another extreme also. If it is less than 10%, that means we are failing in providing maternal care to our women. And where the section rates are lower than 10%, women are actually dying, women and babies are dying for want of facilities and Caesarean section. So it is true that we need to bring down Caesarean section rate, but it is also true that we need to make Caesarean sections safer. Like ma'am was saying about Parkrita, I have a feeling that the single layer closure is one of the probably culprits. Even today, we were talking, me and my friend in our IVF center, that a lot of people, she said, are ma'am doing single layer Caesarean section, although the evidence does not support that. But they are in such great hurry. They always tell you that in 20 minutes, they are doing Caesarean skin to skin. What is the big hurry? I don't understand. Why do they have to do in 20 minutes and why not do a proper job? Because after all, the patient that we operate is the most important at that point of time. So with this thought that we need to make our sections safer, that it is not just important to learn the technique of Caesarean section, but also to look after that the patient does not have sepsis, patient does not have a thromboembolic phenomena, that how do we make it more friendly, more safer, and a better experience for the patient when she is having Caesarean section. So we have got 3 talks by 3 stalwarts focusing on these 3 areas today. And I'm sure we will all learn from each other. Thank you very much. You're muted, Pancham.
Thank you so much, ma'am. Moving on to our first session of the day, preoperative antibiotic prophylaxis. Whom to give, when to give, and for how long to give. Let us hear from Dr. Sonia Nayak, ma'am, who is a director at Cloud9 Hospital, Kailash Colony, an executive member of Endometriosis Endoscopy Society, and with a key interest in endoscopy. And she has been recently awarded a Lifetime Achievement Award in Maternal and Child Health. Thank you, ma'am, for gracing the occasion. I would request the experts of the day, Dr. Reva Tripathi, ma'am. She's a senior consultant and head at Sitaram Bharatiya Institute. Who doesn't know her? She's an ex-director professor at MAMC, and has been a mastermind behind the CS audit process and been an active member of expert committees of Government of India, MCI, ICMR, Ministry of Health, National Board, and UPSC. A warm welcome to you, ma'am. Dr. Deepika Deka, ma'am, who is a senior consultant fetal medicine in Dwarka, an ex-professor in unit at AIMS. He has recently started a new group on obstetricians with the fetal medicines combined, and numerous awards and accolades. I welcome you, ma'am, to the session. I request Dr. Vandana Gupta, ma'am, who is senior consultant in Max Hospital, Patparganj, and vice president, Delhi Gynae Forum South, with keen interest in endoscopy and emergency obstetrics, and a President's Appreciation Award on WOW India 2017, and a great academician. I welcome, ma'am. So over to Dr. Sonia Nayak for this first session on antibiotic prophylaxis. Sonia, ma'am, you can start your screen sharing.
Good afternoon, everybody. Thank you, DGF, for giving me this opportunity. So, I mean, this is a very apt topic for the times now. And as both the ma'am said that, I mean, there's so many things that we actually look into. And so let's have an insight into all these things today. Now, cesarean section is notably the most important risk factor for postpartum maternal infection with a 5-fold to 20-fold increased risk compared to vaginal birth. And the surgical site infections are actually infections of the incision or the organ or the space that occur post-surgery. So the infections that can affect the pelvic organs, the surgical wound, the urinary tract actually are together known as post-cesarean infections. And they can sometimes be serious infection complications like abscess, bacteremia, septic shock, necrotizing fasciitis, and septic pelvic vein thrombophlebitis. Now, what are the main causative agents for cesarean section infection in order to discuss about the antibiotics? So we know that they are commonly polymicrobial, and they can be because of the vaginal colonizers or the pathogens isolated from the endometrium, which includes the E. coli, anaerobes, gram-negative worms, and mycoplasmas. Now, ureaplasma is usually isolated from the upper genital tract and the infected wounds. And wound infections per se are caused by Staph aureus and coagulase negative staphylococci, which arise from contamination of the wound with the skin colonizers or the endogenous flora of the skin at the time of surgery. So basically, the wound infections, we have to be very careful. They arise from the contamination of the wound with the skin colonizers itself. So over here, the importance of the skin scrubs. Now, the factors which are associated with the increased risk of infection and the morbidity after the cesarean section, they can be surgical as well as host factors like the type and the duration of the surgery will impact this, preoperative preparation, operative techniques, surgical skill of the surgeon, rupture of the membranes or intact membranes, vaginal examinations during labor, and the increased blood loss. They all together affect the kind of infections that a person can have. And then the host factors, advanced stage diabetes, obesity, malnutrition, anemia, pre-existing UTI, they are also known to impact the kind of infections that the lady can have postpartum after cesarean section. Now, it has been observed that without prophylaxis, the incidence of endometritis is about 20%. Rates of the wound infection and the serious infectious complications as high as 25%. Now, this was a Cochrane trial, and they analyzed antibiotic prophylaxis versus no prophylaxis for preventing infection after cesarean section. And the conclusion was that prophylactic antibiotics should be routinely administered to all women undergoing cesarean section to prevent infection. And they compared with the placebo or no treatment. And it was seen that the use of prophylactic antibiotics in women undergoing cesarean section reduced the incidence of wound infection, endometritis, and serious complications by 60 to 70%. So traditionally, antibiotics were given at the cesarean section after cord clamping due to several potential concerns of the infant. But however, now there is strong evidence that they should be given prior to the skin incision, and that reduces the risk of post-op endometritis and surgical site infection by approximately 50%. Now, this was published in NEJM in 1992, and they actually saw, they observed what was the actual timing, what should be the timing of prophylactic administration of antibiotics to reduce the risk of surgical wound infection. So like the timing is very important, and it started traditionally before. So now Berkey was the person who hypothesized, and he observed that if you administer antibiotics shortly before or after inoculation of the Staph aureus into the skin, it reduced the size of the ensuing skin lesion. So shortly before or after the inoculation. Now, with each delay of an hour in the administration of the antibiotic, the lesion became larger, and by the 4th hour, the lesion was as big as in untreated animals. So what is the appropriate time of the antibiotic, therefore? So the optimal time to administer the antimicrobials is to ensure effective concentration throughout the surgery. And therefore, the timing is of paramount importance because the goal is to have adequate tissue levels before exposure to a pathogen. So they did a study in which they actually divided the patients into different categories depending upon the time which they received the antibiotics. So the patients who had received the antibiotic 2 to 24 hours before surgery were called as early, and 2 hours before the surgery as pre-operative, and those who received antibiotics 3 hours after surgery, peri-operative, and 3 to 24 hours after surgery were labeled as post-operative. So these were 4 groups, and they compared the infection rates in these 4 groups. So 2 hours before surgery, 2 to 24 hours before surgery, 3 hours before surgery, after surgery, and more than 3 hours after. So the lowest rate of surgical wound infection was seen in the group who received antibiotics 0 to 2 hours before surgery. So this was the time that they observed that in which if the antibiotic given led to least infections, wound infection. So the lowest rate of surgical wound infection was seen in the group who received antibiotics 2 hours before surgery, and patients who received antibiotics within 3 hours after surgery. The wound infection rate was 1.4%, and more than 3 hours after incision, 3% wound infection. So there is an increased infection even if the antibiotic is given shortly after surgical incision is made. So therefore, it is important that you give the antibiotic pre-operatively and not post-operatively or peri-operatively. So surgical data suggests therefore that for antimicrobial prophylaxis to be effective, it should be given at least 30 minutes before cesarean section to ensure a bactericidal concentration which is reached by the time of incision. So now the next thing is which antibiotics. So we have discussed the timing of the antibiotic. Now which, and we have discussed whether antibiotic should be given or not. Yes, according to the Cochrane first trial. Second, the timing we have discussed. So at least 30 minutes to 2 hours before. Now third, which antibiotic should be given. So this was another Cochrane trial. So the common antibiotics we know are the cephalosporins and the penicillins, and first, second, third, we all know about them. And the natural penicillins, the broad spectrum penicillins, the penicillins plus the beta-lactamase inhibitors, that is the amoxiclav and the ampicillin with the sulbactam. Now, there may be little or no difference in the short-term outcomes between the anti-staph cephalosporins, that is the first and the second generation, and the broad spectrum and penicillins plus beta-lactamase inhibitors as prophylaxis for the women undergoing cesarean section, although the impact on post-discharge infections and outcomes are not known, as is the impact on bacterial resistance. This was a statement made by WHO in 2015. Now, WHO recommendations on prophylactic antibiotics for women undergoing cesarean section in 2015. There was few points to be noted, and there's a lack, according to them, there's a lack of clear difference between the efficacy of first and second generation cephalosporins. And they also noted that the evidence suggests that third generation cephalosporins may be less effective than penicillins for this indication and should be avoided therefore. And the first generation cephalosporins therefore are preferred for prophylaxis in general surgery as part of efforts to contain antimicrobial resistance. And a single dose 30 to 60 minutes before surgery antibiotic regime for prophylaxis is recommended, therefore. And due to the increased risk of necrotizing enterocolitis among preterm babies exposed to amoxiclav, the use of amoxiclav for antibiotic prophylaxis should be avoided before cord clamping for cesarean section of preterm infants. And now this was a Foxy Focus statement in 2018 that antibiotics that are effective against gram-positive, gram-negative, and anaerobes should be the appropriate choice. And therefore, they came up with the choice that 1 gram of intravenous cefazolin, that is the first generation cephalosporin, is an appropriate antibiotic choice with an increased dose 2 grams indicated for obese women. So 1 gram single dose cefazolin 30 to 60 minutes for the surgery. Now, let's look at the ACOG, what they say about the antibiotic prophylaxis. Again, over here, should be administered within 30 minutes before the start of the surgery. And if not possible before 30 minutes of the surgery, that means an emergency surgery, administer as soon as possible after the incision. And again, the weight, 1 gram cefazolin, according to the weight, more than 80 kgs, give 2 grams. And if a person is allergic to cefazolin, then 900 milligram clindamycin plus 5 milligram per kg aminoglycoside. And to be continued, the ACOG recommendations, they said that there is evidence that azithromycin may be an alternative or adjunct to first generation cephalosporins. That means 500 milligram azithromycin IV over 1 hour may be considered for women undergoing non-elective cesarean. So emergency cesarean section, they said you can add intravenous 500 milligram azithromycin. And in obesity and post-cesarean section prophylaxis, this 500 milligram oral cephalexin and 500 mg metronidazole every 8 hourly can be added for 48 hours. So this is the only post-operative indication that I've observed in all the studies according to the CDC, WHO, ACOG, FOXI, all of them saying that it's a single dose cefazolin 30 to 60 minutes before the surgery, but ACOG says that you can add cephalexin plus metronidazole for 48 hours every 8 hourly, if in case it's done for a post-cesarean prophylaxis and obesity. Now, longer procedures, that means longer procedures means it's more than the half-life of the drug. So then if then more than 4 hours of the surgery, that means you will repeat a cefazolin dose again. Or there's excessive blood loss, that means more than 1500 ml. Again, an additional intraoperative dose of the same antibiotic. Now, PPROM, we already know about it, so I'm not going to the details of that. And again, to be continued, manual removal of placenta following vaginal delivery, again, data lacking, but common to provide prophylactic antibiotics due to high risk of infection. Postpartum DMC, no data to recommend for or against prophylactic antibiotics. Indwelling balloon catheter for management of PPH or retained placenta, again, no data to recommend for or against prophylactic antibiotics. Cerclage, again, insufficient evidence. And 3rd and 4th degree lacerations, single dose of antibiotic at the time of repair is reasonable. Now, the last thing runs, how long to give the antibiotics. So till now, we actually observed that according to all the recommendations, single dose antibiotic. Now, are there any indications for a post-operative antibiotic? Now, after emergency cesarean delivery with a povidone iodine skin preparation, routine use of prophylactic post-operative antibiotics does not appear to reduce the rate of postpartum infection, according to the CDC. Now, these were the trials, randomized controlled trials, which were done to actually know if in case a post-operative prophylaxis is required or not. So this was single dose versus multiple dose antibiotics prophylaxis for preventing cesarean section postpartum infections. This was a randomized trial published in 2022, and patients were distributed randomly into arm A and arm B. So arm A was intravenous ceftriaxone and metronidazole 30 to 60 minutes before incision. Arm B was cefuroxime 500 milligram, the IV ceftriaxone and metronidazole plus cefuroxime post-operatively and metronidazole for 5 days in addition. So the patients were monitored for 2 weeks for any wound infections, and the result was there was no statistical difference in the incidence of wound infection and febrile morbidity. So the conclusion was that single dose ceftriaxone or metronidazole plus metronidazole is as effective as multiple doses for antibiotic prophylaxis to prevent post-cesarean infections. Similarly, another randomized controlled trial was done comparing ceftriaxone versus triple drug regime. So the triple drug regime was AMPI, Genta, and metronidazole. So no statistical difference was seen in the mean duration of the hospital stay, no difference in the But a significant difference was found in the mean cost. So the group of patients taking the multiple doses and the 3-drug regime, they had the mean cost of treatment was higher in them. So the study groups did not differ significantly in the incidence of endometritis, UTI, wound infections, and febrile morbidity. So the single dose ceftriaxone was as effective as a combination of ampiclox, gentamicin, and metronidazole in preventing post-elective cesarean complications. Now, other than the antibiotic, other infection prophylactic measures according to CDC 2017 is that before surgery, we should ask the patients to have, they should shower or bathe full body with soap or an antiseptic agent, or at least on the night before the surgery. Proper hand scrub of surgeon and assisting team is most important. Skin preparation in the operating room should be performed using an alcohol-based agent unless contraindicated. For clean contaminated procedures, additional prophylactic antimicrobial agent should not be administered after the incision is closed in the operating room, even in the presence of a drain. Topical antimicrobials should not be applied to the surgical incision. During surgery, glycemic control should be implemented using blood sugar target levels less than 200 milligrams. And normothermia should be maintained in all patients. Increased fraction of inspired oxygen should be administered during surgery and after extubation in the immediate post-op period for patients with normal pulmonary functions undergoing GA with endotracheal intubation. And the WHO recommendation on the vaginal preparation with antiseptic agents for women undergoing cesarean section. All the women undergoing cesarean section should have vaginal cleansing with povidone iodine 1 to 10% for 30 seconds, performed immediately before cesarean section. And alcohol-based antiseptic solutions should not be used for vaginal preparation. Vaginal preparation should be performed as close to the start of cesarean section as possible. And the skin preparation, so WHO recommendations on the choice of antiseptic agent and method of application for preoperative skin preparation, WHO 2021, that the use of alcohol-based chlorhexidine gluconate for skin preparation prior to elective or emergency cesarean section is recommended. Most of the trials use 2% chlorhexidine in 70% alcohol. And where chlorhexidine gluconate is not available, other antiseptic agents like povidone iodine can be considered as a suitable antiseptic agent for preoperative skin preparation. So therefore, the take-home message is that prophylactic antibiotics should be routinely administered to all women undergoing cesarean section, administered within 30 to 60 minutes before the start of the cesarean delivery. 1 gram of intravenous cefazolin is an appropriate antibiotic choice with an increased dose indicated for obese women, and there's no role of post-operative antibiotics. Thank you.
Thank you so much, ma'am. That was really enlightening. I would request our experts, Dr. Reva, ma'am, if you would like to share your expertise on this topic.
Thank you, Dr. Pancham. And wonderfully summarized, I must say, by Dr. Sonia. Just a couple of points, if I may add, with your permission, Dr. Sonia.
Yes,
one thing is that many times a lot of the studies that you quoted were all Western and CDC and other things. I just want to say that this antibiotic resistance, which is kind of coming in such a huge way, and we're talking so much about preventive measures for that, it has been studied in the Indian setup also, because we all tend to say, oh, their standards are higher than ours, and therefore everything that we read in the literature cannot be extrapolated to our setup. But I'm happy, and I'm sure, I don't know whether anybody's here. We know that from Harding, Dr. Manju Puri has put in a paper, and there was another paper from the Aligarh Medical College, both high-load government facilities, who have also reduced their antibiotic exposure and not found any problem. And they've not found any increase of their SSIs or something. So that means that their Western recommendations can, for this particular situation, be extrapolated to the Indian context. The other thing that I would just like to suggest is that it would be great if every center, especially a large volume center, could have their own local cultures. So they identify the bacteria and they identify their antibiogram so that they could consider if they need to or they want to change the standard recommendations. Otherwise, 1 gram of cefazolin is kind of now becoming standard. The other thing that we need to look at is the MRSA that is coming up these days. And it could be a problem in some patients, especially those in the large government hospitals coming in from the periphery and other things, where you may need to consider to add vancomycin. Now, that's an important point to note that it has to be added. It is not a question of a substitution for the MRSA. The last point that I would just like to talk about is the timing of the drug. So there has been a bit of a seesaw earlier. It used to be started long time back, a long time prior to the surgery. And then there was this thing that we can bring it closer to the time of the surgery. And this has been a seesaw whether we should give it after the cord clamping or before. So I know that the ACOG and the WHO and all are all recommending to give it 60 minutes before. But there are a couple of papers coming in about giving it after the cord clamping. And now that we are becoming more aware of infant microbiome and other issues like that, so maybe there may not be very many short-term issues associated with giving it prior to the incision, which is what the standard recommendations are. So there was a study, I just happened to chance on it, published in 2022, which had done a comparison between, it was published at the British Journal, and they have talked about a comparison between the standard pre-op, which is what is being followed many places, and the after the umbilical cord clamping. And they say that there is no difference in terms of the SSI and other things. So I think it is something that we need to consider, and because it involves long-term effect on the children. So it is future that will give us the answer to these questions, but it is something that we can keep in mind. And the last thing before I sign off, I would just like to say that I think every issue, just like we've always taught, done, and taught our juniors, is to individualize your patients. So the same thing cannot be talked about for an elective or a clean case versus a patient who has been in labor with ruptured membranes for a long time, who is obese or has had multiple PVs. So you need to kind of take obviously an informed decision about which category of patient you're dealing with and modify your routines accordingly. Thank you very much.
Very valid points, ma'am. But certainly, I also went through this study of giving the antibiotic post cord clamping. But while I was at Max, we had, there was a huge, there was a very large infection control committee, and they used to study all the cases of post-operative wound infections. And in them, they had studied all the cases in the, basically in general surgery, and they came to the conclusion that we should give the antibiotics just pre-operatively.
You see, in general surgery, they're not bothered about a baby. So that's something that we need to keep in mind.
Not just the general surgery, which include the OBGYN.
No, that's what I just said, that, now we are coming up with these studies on the microbiome, and they're going to grow only larger in volume. So the effect of the pre-op or pre-incision antibiotic timing versus the post-cord clamping, I think we will see a lot of talk about this in the near future, and maybe we could kind of keep our eyes and ears open to this issue, which is important, and it is being touted as one of the reasons why we should be decreasing our cesarean rates also, because we are talking about altering the infant microbiome and the gut infant microbiome, and therefore we should be looking at this and keeping this at the back of our minds, and generating our own data. That would be great, rather than just relying on what ACOG or other people are saying.
Definitely. Thank you so much, ma'am. Dr. Deepika, ma'am, would you like to add on to this?
Thank you, Dr. Renu, for inviting me here today. Well, I think a lot has already been discussed. So there's really not, I don't want to add on to the discussions of earlier. What I just want to say is that the timing is important because I remember our pediatricians, neonatologists. Maybe we can change the slide or remove this slide. We can remove the slide. Let's see others' faces. So they were very concerned, especially in women who had premature rupture of membranes, who had received antibiotics much longer earlier than when we did the cesarean section. And they were worried about a neonatal sepsis. No, so of course, Sonia, you've talked about it, but neonatal sepsis, they attributed a lot to indiscriminate use of antibiotics. And not just labor, but also cesarean section as well. Then there comes a problem of sensitivity. You know, if you have someone who's sensitive to cephalexin, to the first generation antibiotics that we give, then that becomes a problem. And we were taught earlier also that when you have a cesarean done, the first thing you ask in the history is also, did you have infection at the time of the cesarean, after the cesarean, because it makes the scar weaker. And you know that in my field where you very often need to advise a termination of pregnancy, it becomes very difficult if there has been a weak cesarean section scar. And weakness, of course, will come from the infected scar. So it's very important that antibiotics are given and that prevention of any infection by very good cleaning antibiotics, vaginal clinic, should be done. Because I've seen now, you know, in AIMS, we were taking all sorts of risks, but I've seen now in practice that even early pregnancy, termination of pregnancy by medical abortion in a woman with a previous section, irrespective of whether she had an infection or not, people are scared to do. They think that their uterus will rupture. So I think these are some more issues that we really need to concern ourselves with. And certainly the scar should be good, because as an ultrasoundologist, for me, if there is a very ugly looking infected scar, ultrasound visualization in the next pregnancy becomes very difficult. So this is one more tiny reason why there should be no infection, why we should do all activities to prevent any scar infection, especially when we have such good antibiotics, such safe antibiotics with us. Thank you.
Thank you so much, ma'am. This was really enlightening, and I would request Dr. Vandana Gupta, ma'am, to share her views on this, please.
Yeah, thanks, Dr. Renu, for inviting me for such an important topic. And it's a very pertinent and a relevant topic. And all really has been said. And I'll just share that what I do in my private practice, that with the initially we were giving antibiotics for 5 days. But with the so many research papers and so many talks going around, and the data coming from our own medical colleges reassured us as a private clinician that single dose would be more than enough. So what I do is give a single dose, 30 minutes. I target 30 minutes because at times we are still late in carrying. So I don't want to delay for more than 1.5 hours. So I target 30 minutes before, give metronidazole and first generation cefazolin, and that's all. And I've seen really good results. But yes, those special cases, patient has comorbidities like diabetes mellitus, or there has been a premature rupture of membranes, even in vaginal delivery. If the premature rupture of membranes has been before 8 hours, we do have to cover with an antibiotic. Even then the child is exposed. So the studies have to definitely go on, and we have to judge ourselves case to case basis. And just before inserting the Foley's catheter, deep vaginal cleaning is done. So that is on the operative table. So that is also really brought down I think so, that is contributed to bringing down the ascending infection rates, and things should start looking up better. And the antibiotic prophylaxis should be limited at the max, if still the surgeon is scared, to 24 hours at the max.
Thank you, ma'am. Dr. Renu, ma'am, you wanted to say something?
Dr. Deepika wanted to say something.
Now, I just wanted to know the consensus about giving metronidazole.
Ma'am, metronidazole, because ascending anaerobic infections are really common from the vagina. So that is the thing. How far are patients?
Because there are no directions from WHO.
I know.
No
I also
direction, but
wanted to ask the
yeah,
same
from the
question.
general private practice point of view.
For private
that-
or that doesn't matter, Vandana. Patient is patient, but I also had the same query that normally we say this one shot of
One
whatever
shot.
was second
Achha,
generation.
yeah.
But should we give metronidazole? Is there any clear guidelines, Sonia?
Not guidelines, ma'am. See,
No,
they
ma'am.
were using
There's no
metronidazole
guideline.
initially also.
Dr. Sharda, ma'am, what is your?
The guidelines, if I can.
I do
add in.
not use metronidazole.
Ma'am,
Yeah, even
ma'am,
I
the-
don't.
Yeah, the guidelines which are there for preterm for any prom, if you do cesarean or for emergency cesarean sections, it is to give a single dose of azithromycin along with the cefazolin or
Yeah.
ceftriaxone, whichever
That she
we are
told.
doing.
May
So
I,
that's
may
the
I
only
come in on this?
guideline which is there, yes.
May I come in on this?
Yeah.
I think azithromycin is an issue with beta streptococcus, which is not such a big problem for us. And there are some papers which are talking about adding a single dose of metronidazole to the cefazolin, especially in those patients who are morbidly obese. And there have been some papers which have said that for the or with some kind of other comorbidity, and said that that might bring down the infection rates. I think it's not a problem that has been addressed properly, or a very great study done, or a head-to-head kind of a comparison, which is what would be required to give an exact comparison. But this is what I actually meant when I said about individualize your patients.
Right.
Because for patients who have had a longer duration of a prom, or who've had or who are obese, it could be considered to add this one dose of metronidazole. Because they don't talk about increasing the duration. They still talk about the single dose, but rather than have just the cefazolin, they're adding a single dose of metronidazole also.
No, Dr. Sonia Naik specially mentioned that in an obese patient, the WHO guidelines is there to cover it for 48 hours along with the metronidazole.
Yeah, so it should be not just obese, but somebody, I mean, an elective
Long
cesarean.
surgery.
When you say elective and emergency, it actually doesn't give a clear picture. Because if you're doing somebody in emergency and she's not been in labor, she's as good as an elective. Somebody who's in labor or had PV or had PROM, then it should make a difference, isn't it, in what we are giving?
So basically intrapartum cesarean, you're right there.
Yeah.
Rather than patient has been in labor and then needed to go for a cesarean for some particular reason. And obviously the duration of labor is substantial, not the duration of labor of just coming in and for a short while. So that stands to reason.
So maybe we can adopt that 48 hours protocol for these women where the risk is slightly higher.
So, you know, this thing about single dose, at some point of time, there was this talk of 3 doses. And then if you have 48 hours, you have 4. So it's a bit, may I say, undecided.
Josna also has done the study in Safdarjung Hospital. She should also enlighten us about the change in emergency and elective cesarean section. Dr. Josna?
Yes,
But it's been now almost 15 years that we've been using only single dose antibiotic. We have not been using even metronidazole or gentamicin to our antibiotic regime. We've been using for the last 15 years, as far as I remember, at least only a single dose antibiotic.
Also,
So you are not modifying for
Even in
obesity
obese
and for
patients, even in diabetic.
intrapartum cesareans, etc. For long-term patients who have had a prom and then who've gone into labor, who have been induced and gone into labor and all that.
Definitely in them we have added, ma'am, but not, I mean, otherwise, even in obese diabetic patients, we've been only using a single dose. I mean, a single
Elective
antibiotic.
cesarean. If
Single
you're doing an
antibiotic, whether it's OBGYN, any procedures.
yeah, Dr. Jyotsna, you want to add something?
yes, ma'am. Sharda ma'am has just actually she knows about that study we had done. So here in this, when we are doing in the laboring patients or in those with PROM, we have been doing the single, vaginal cleansing with the,
Povidone.
that we have found very useful. We don't use the iodine preparation, but we have used the cetramide along with this thing, chlorhexidine. So that combination we have used, and we have found a substantial decrease in the SSI after cesarean section. So that is in the process of publication, that study. So we are doing that particular intervention. When we do
What you're saying is you don't clean the vagina with povidone iodine, you're doing it with chlorhexidine and cetramide.
Yes. So actually, vaginal cleansing before cesarean section, our pediatricians have an issue if we use iodine based, because it can interfere with the thyroid, neonatal thyroid screening. So we have been very strictly in our hospital, it has not been encouraged. So we use this, and now the WHO, we have found many papers, and even the WHO is now recommending that we should be using this compound rather than the iodine based. That is a long standing thing, that iodine based was being used, but now this is coming into the limelight, that using chlorhexidine with the cetramide combination, it may have a better, wider coverage.
ACOG is also recommending the same thing.
What
Yes,
is what does it come for?
Ma'am, the name is cetavilon.
Cetavilon.
Yes.
But how can cleaning the vagina with iodine cause problem with
yes, ma'am. So I also have not got the evidence about it, because when I was giving my PG this study, so our pediatric department did not allow it in the ethical clearance, that there is a problem for the neonatal thyroid screening. So I had gone into the evidence. There were few papers which were published, but there is no strong evidence about it. So therefore, we were forced to use another compound, but later we have found now that this compound is actually doing better. So now, in fact, we are happy we use this one, and it is now being recommended by many of the organizations to use this cetavilon.
Something
I must say, dunya goal hai. When I was a resident, then Cetavlex cream was being used right, left, and center for PVs.
Yes, we've also used that. Yes.
But that is out of my.
No, but the point is that then with things which we did 45 years ago and which was discarded, कि आप लोगों ने गलत करा, वो गोल घूम करके फिर वापस आ रहे हैं. So that's something that we need to contemplate, and that's why you probably need to be abreast with what's going on, because some things that you think are discarded, they just come back unexpectedly.
Right. True. We just need evidence now.
Thank you so much, ma'am. Thank you everyone for your expert comments. Moving on to our second session. Are we scared of DVT? Does it mean we need to give thromboprophylaxis to all? Definitely not. So how to prioritize, how to try it? Let us hear from Dr. Jyotsna Suri, ma'am, who is Professor Unit Head and in charge, Critical Care Obstetrics at Safdarjung Hospital. She's a chairperson, Safe Motherhood Committee, and has delivered more than 200 guest lectures. Who doesn't know her, and is a PI in Action 3 WHO trial. So I welcome you, ma'am. The experts for the session will be Dr. Harsha Khullar, ma'am, President, Delhi Gynecologist Forum Central. She's a senior consultant in Department of Obstetrics and Gynecology at Sir Gangaram Hospital, and is past President ISOPAP Delhi branch with a special interest in oncology and a great obstetrician herself. I welcome you, ma'am. Dr. Archana Pathak, she's Director of Obstetrics and Gynecology at CK Birla Hospital, Punjabi Bagh, with a special interest in managing high-risk pregnancy along with hysteroscopy and laparoscopy, and has recently received the APJ Abdul Kalam Appreciation Award from Delhi Gynecologist Forum. A warm welcome, ma'am, to the session. Dr. Surekha Jain, who is Secretary, Delhi Gyne Forum North. She's a senior consultant at Fortis Shalimar Bagh, and I welcome you, ma'am, on the session. Let's hear from you, Dr. Jyotsna, ma'am.
Yeah. So I'll
yes,
share my screen. Yeah.
Yes, ma'am.
Is it visible?
Yes.
It's visible, ma'am. You can put in slideshow.
Yeah, I have put it. So thank you so much, At the outset, I want to thank Dr. Renu Mishra for giving me this opportunity to talk about this important topic, and also to think about, this concept of safe cesareans, which actually touches the life of each and every one of us. So to begin with the talk, thromboprophylaxis in cesarean section is what has been given to me. And I start with a case which is actually a true case which happened in our hospital. So a 32-year-old para 2, live 2, day 2 of emergency cesarean done for deep transverse arrest, complaint of breathlessness. The resident doctor examined and found that all her vitals were within normal limits. Her ABG was also within normal limit, and saturation, which was initially 94% on room air, picked up to 98% within a few minutes. Patient was dehydrated and was given a bolus of ringer lactate. She was completely asymptomatic when the consultant saw her after 30 minutes. And so instructions were given to keep the patient under monitoring without any additional treatment. 8 hours later, the patient again had shortness of breath with circulatory collapse this time, and she was transferred to the ICU in an intubated state, put on the vasopressors. Her echo was done urgently, which revealed right ventricular dilatation, and ABG showed predominant respiratory alkalosis. The D-dimers were raised, and on a strong suspicion of pulmonary embolism, IV unfractionated heparin was started. However, the patient succumbed within 2 hours. So this is a case which has taught us many lessons, that when we have pulmonary embolism, it may not always come as a catastrophic event, but it does have small, when the emboli are small, it may just have a transitory deterioration of the patient, which she may improve after some time. So, and a cesarean case, we should be very, very alert when anyone complains of shortness of breath. But why should this situation happen? Why do we need to have, this kind of situation in a patient who is high risk? So herein comes the role of thromboprophylaxis. So the objectives of this session is the rationale for thromboprophylaxis after cesarean section, what is the pathogenesis of DVT in obstetrics, and what is the clinical feature, a quick discussion about that, followed by the risk factors for DVT in the postpartum and post-cesarean period, and then the thromboprophylaxis during pregnancy and postpartum. Mainly, we will be focusing because the topic is after cesarean, so my focus will remain. So talking about what is the rationale for thromboprophylaxis. So venous thromboprophylaxis, or VTE as it is called, it is a entity which discusses both the DVT and the pulmonary embolism. So when we say VTE, the majority of the cases are the DVT, that is 80%, and pulmonary embolism is 20%. The incidence is about 1 in 1,000 deliveries. In 30% of the cases, pulmonary embolism can occur without DVT. So this is, very, very disturbing, that as was the case even in what I narrated right in the beginning, there was no evidence of DVT, but it is a fact that 30% cases can directly throw an embolus without any clinical evidence of DVT. Then in 40% cases with symptoms of DVT, there can be a silent pulmonary embolism, which will not be very symptomatic in the beginning, but later on, it can just have a catastrophic presentation. The pregnant woman is 5 times more likely to develop a venous thromboembolism. Frequency of thrombosis is similar in all the 3 trimesters, but increases 3 to 5 times in the purpurium. Then another very important fact is that 15 to 25% of all the venous thromboembolism in pregnancy are recurrent. And it has been seen that in these particular patients, about 25 to 50% of the cases are associated with thrombophilias. So with this, background, we move ahead for, what is the rationale for thromboprophylaxis after cesarean. So pulmonary embolism is a very common cause of maternal mortality, especially in the Western countries where hemorrhage and sepsis is not of great concern. In many of the countries, it tops the list of the maternal mortalities. The second is that over 80% of fatal purpureal pulmonary embolisms occur after cesarean birth. So this is a very important message for all of us, that we should carry in mind that when we are doing a cesarean, besides the other complications, we are putting our patient at a very high risk for having a VT, venous thromboembolism. So now coming to the pathogenesis. So why is it that pregnancy and postpartum period are so vulnerable to have the VT? The first is that there is an activation of the Verco's triad, which we all have learned as students. So this is a triad which has got, the three things which are there in this are the venous stasis. So there is a decreased venous tone, and during pregnancy, this is due to the hormonal reasons as well as the anatomical reasons, the compression of the gravid uterus, and the venous pooling and valve incompetence takes place because of this. Then second is the hypercoagulability. That is basically a mechanism of nature to prevent increased bleeding in the purpurium and after the delivery. But it is a double-edged sword and it can lead to the thromboembolism. So increased coagulation factors which progressively increase as the pregnancy progresses. So several of these factors, which include 1, 2, 7, 8, 9, 10, along with a decrease in the protein S. And the last but not the least is the endothelial injury, which is maximum seen after delivery, especially a traumatic delivery and after the cesarean section. So these three are the main causes for increase in the incidence of venous thromboembolism after delivery, and of course during pregnancy also. So now, what are the clinical presentation of the DVT? So one very important and startling fact about DVT in pregnancy is that it is very often that the proximal veins are affected. Rather, in the general population, hardly ever the proximal veins are affected. But in pregnancy, it is a very common thing. And out of the two, the left lower limb is much more commonly involved as compared to the right. And this is so because of the compression of the left iliac vein by the right iliac artery. And as I said, that it is common in the proximal veins, that is the femoro-iliac veins. So it is said that about 10 to 15% of all the DVTs in pregnancy and postpartum period are in the proximal veins. And sometimes it may be isolated only in the femoral vein. And pelvic vein thrombosis is very rare outside of pregnancy. So how do this DVT present? So DVT will present normally as a diffuse pain and swelling that may or may not be associated with erythema, warmth, and tenderness of the lower extremity. The symptoms of iliac vein thrombosis, they will be the swelling of the entire leg with or without flank pain, lower abdominal pain, buttock pain, or back pain. So we should be very cautious of these symptoms also, the buttock pain and back pain, which are very characteristic with the iliac vein thrombosis. Initially, the swelling may not be there. Later on, this is the full-fledged picture of the proximal DVT, and this is of the distal DVT. But it starts with a very unusual and unremitting pain in the back, lower back, and in the buttock area. So the investigations we all know, I will not be talking too much about this because the main topic is the thromboprophylaxis, but we normally go in for the compression ultrasonography and Doppler imaging. And the gold standard, of course, is the CTPA, the CT pulmonary angiography, if you are suspecting a pulmonary embolism. But in pregnancy, normally we prefer a VQ scan if it is available. And for the lower limb Doppler and the pelvic vein, for pelvic vein thrombosis, we of course prefer to do the compression ultrasonography and the Doppler imaging. And at times the venography or the MRI may be added if it is required. So now coming to the focused part of this talk, which is the thromboprophylaxis. So there are a lot of dilemmas which are concerning this very thromboprophylaxis. Why? Because there are no adequately powered studies which delve into this topic. Second is that the guidelines, many of them are not concurrent. Then there is a risk of wound bleeding and blood transfusions increase when the thromboprophylaxis is given. So there is always a debate whether to give or not to give. What is the optimum threshold for initiation and optimum duration, which is not very clear. And currently there is no validated tool for risk assessment of the patients. So most of us are using whatever are the clinical, risk factors, but we don't have a mathematical model for, just putting in and seeing what is the risk. So that, there are some studies, but not very well validated. So now who is at risk for the development of venous thromboembolism? So let us see. As we said, there are different guidelines. So quickly we'll go through them. So this is the American College of Chest Physicians, the ACCP. So in 2016, they took out a guideline which was for the discussing the VT in the pregnant women, how to prevent. 1 minute, yeah. So yes, so they said that the prophylaxis should be provided after cesarean births to patients with any of the following risk factors. So this were the major risk factors for them. First is a prior history of venous thromboembolism. The second is a history of antepartum immobilization. That means that a strict bed rest for at least 1 week. Then the third they said was a significant postpartum infection or a postpartum hemorrhage more than 1 liter requiring a resurgery. Then next they said preeclampsia with growth restriction. And last was the significant medical comorbidities like systemic lupus erythematosus, heart disease or sickle cell disease or known thrombophilia. So these were the major risk factors and any one of them qualified to give thromboprophylaxis. Then amongst the minor risk factors of ACCP, 2 or more. And in the presence of cesarean birth, they said 1. So here again, they said that if with a cesarean, any one of these was present, the patient merited a thromboprophylaxis. So these were the postpartum hemorrhage, more than 1000 ml, not requiring reoperation, BMI more than 30 kg per meter square, fetal growth restriction, preeclampsia, multiple pregnancy, and tobacco use during pregnancy, that is more than 10 cigarettes per day. So coming to the RCOG guidelines, which all of us, I think, are using very often to decide about the risk scoring for our patients. So RCOG in 2016, they have said that all women who have had cesarean sections should be considered for thromboprophylaxis with low molecular weight heparin for 10 days after delivery, apart from those having an elective cesarean section, who should be considered for thromboprophylaxis with LMWH for 10 days after delivery if they have additional risk factors. So in other words, they say that all emergency cesarean sections should have thromboprophylaxis and those with elective should have if they have additional risk factors. So we'll be talking about what are those additional risk factors. So thromboprophylaxis should be continued for 6 weeks in high-risk women and for 10 days in the intermediate risk women. So this was the key message from the RCOG guidelines. So if we see this table which they have given, so here you can see that if the risk scoring has been given and the orange one depicts the highest risk, which is for which more than 4 or equal to 4, the thromboprophylaxis has to be given from the first trimester itself. The score 3, we have to give the thromboprophylaxis from 28 week onward, and if it is 2, then we have to give the thromboprophylaxis in the postpartum period for at least 10 days. So here, if we see this table, so the core score is for the previous VT, except a single event related to major surgery. And for the 3 score is given to previous VT provoked by major surgery, known high-risk thrombophilia, and many of the medical comorbidities like heart failure, cancer, and lupus, and renal diseases, type 1 diabetes, nephrotic syndrome, etc., sickle cell anemia, and the current intravenous drug user. Then they have given family history of unprovoked estrogen-related VT in first degree relative. These are the low risk, so 1 score is given. But if 2 scores add together, then the postpartum thromboprophylaxis has to be given. Then known low risk thrombophilia, who has never had previous VT, age more than 35 years, obesity, parity more than 3, smoker, gross varicose veins. So these are the general risk factors. Then the specified obstetric risk factors have been defined, such as preeclampsia, ART pregnancy, multiple pregnancy. And here we can all see Caesarean section in labor has been assigned a score 2, which says that 2 has to be given postpartum thromboprophylaxis for at least 10 days. Then elective Caesarean, mid-cavity or rotational operative delivery, prolonged labor, PPH, more than 1 liter, preterm birth, stillbirth, and then we have the transient risk factors like the OHSS, any surgery which has been done in the purpurium except for the perineal repair, hyperemesis, and any systemic infection and immobility or dehydration. So this particular, the chart is both for assessing the risk in the antenatal and in the postnatal period. So we are not going to talk too much about antenatal today, even though the risk factors which are there in antenatal in the postpartum, they will be getting the thromboprophylaxis. But we'll discuss more about the postpartum today, because we are talking about the Caesarean sections. So the postnatal, so what they recommend is that in the postnatal suite, the patient has to be reassessed. And again, now, as we discussed in the previous slide, that you see what is the risk for her to develop VTE after delivery. So the delivery may be normal delivery or it may be a Caesarean. So here again, as we see in this one, any previous VT, any one requiring antenatal LMWH, high-risk thrombophilia, and low-risk thrombophilia plus family history, they now come into high risk who need 6 weeks of postnatal prophylactic LMWH. And Caesarean section in labor, BMI more than 40, readmission in the postpartum period for more, or admission for more than 3 days, they all come in the intermediate risk, and of course medical comorbidities. So they will need for 10 days. And over here, these are the lesser risk factors, but if the 2 or more combine, then they again merit thromboprophylaxis as per the RCOG. So now coming to what is the, what kind of thromboprophylaxis we should be giving to the low risk Caesareans. So the ACOG says that use pneumatic compression device on all patients before even they are being wheeled into the cesarean, and encourage early ambulation after cesarean birth as soon as 8 hours post-operatively. Pneumatic compression devices may be removed while the patient is ambulating, but should be put back on when they return to a seated or a supine position. So for all low-risk cesarean, ACOG is advocating pneumatic compression, at least intermittently when they are not ambulating. RCOG, of course, for fewer than 2 risk factors, they have not said that use pneumatic compression, but they say early ambulation and avoid dehydration. And ACCP 2016 says for patients whose only risk factor for VT is pregnancy and cesarean birth, the ACCP recommends only early ambulation postpartum. So we can all see that the ERAS guidelines, which will be discussed, and they focus on the early ambulation, how important it is for prevention of the DVT and the pulmonary embolism. So now the pharmacological thromboprophylaxis, what are the drugs and what are the doses? So the drug of choice, we all know, we are all very familiar. It is the low molecular weight heparin, and the unfractionated heparin is also useful in cases where there is a kidney disease with a creatinine clearance less than 30 ml per minute, or a rapid discontinuation may be required near delivery or in the perioperative period when immediately after cesarean section, if she is a very high risk patient and we need to start the thromboprophylaxis, then we prefer the unfractionated heparin over LMWH. Warfarin is given if thromboprophylaxis is required for 6 weeks and in the patients who are not willing to take the injections at home. So warfarin becomes the drug of choice when a longer thromboprophylaxis is advocated because it is safe in the lactation. So warfarin we should not give at least for 3 days postpartum, and it is all, as I said, it is only given if we need to give it for a long period of at least 6 weeks. And we give it after 3 days we start, and we always overlap it with the heparin. And once the INR is between 2 and 3, we stop the heparin and continue the warfarin. So during lactation, warfarin and heparin are safe because even though they are detected in the breast milk, but warfarin metabolites are inactive and do not cause problem for the baby, and heparin is not absorbed through the GIT of the baby. So these are the 2 drugs which we can give. Then, of course, the other drugs which are safe in lactation, they are the fondaparinux and the danaperoid. But these 2 drugs, normally we are not using unless and until there is a situation of the HIT, that is the heparin-induced thrombocytopenia. In those conditions, these drugs may be considered, but they are safe, considered safe in lactation. The drugs which we don't give during lactation are the oral direct thrombin inhibitors, that is the dabigatran, and the anti-10A inhibitors, the rivaroxaban, apixaban, endoxaban. They should be avoided in pregnancy and lactation because there is insufficient data to evaluate the safety for the woman, fetus, and the breastfeeding neonate. However, I would like to say that if the patient is not lactating, rivaroxaban has come up as a very important drug. Nowadays, we are giving it in the women in the postpartum if the woman is not breastfeeding. So the nomenclature of dosing, when we talk, it is, the low dose anticoagulation, which is normally the prophylactic, which we say, which refers to the use of low doses that aim to reduce the risk of venous thromboembolism while minimizing the bleeding complication. Intermediate dose refers to adjustment of the prophylactic dose with weight gain during pregnancy. So basically, both low dose and intermediate are used for prophylaxis, whereas the therapeutic dose anticoagulation refers to full therapeutic doses typically reserved for the treatment of thromboembolic disease. However, having said that, despite the nomenclature, therapeutic dosing may be used prophylactically to prevent thromboembolism in individuals at a very high risk of thromboembolism, when lower dosing is thought to be insufficient for thromboembolism prophylaxis. For example, severe thrombophilia or previous history of DVT, she may be having recurrent DVTs, or there may be mechanical heart valves. So this thing we have already discussed. Okay, so what are the doses of the drug? So when we talk of the prophylactic dose, as I said, it is the enoxaparin or the deltaparin, that is the LMWH, which we give, that is 40 milligram subcutaneously once a day, or deltaparin 5,000 units subcutaneously once a day. And if you are using the unfractionated heparin, as for the indications I just discussed, it is the 5,000 units subcutaneously every 12 hours. And intermediate dose is normally given in the antenatal period, because we increase the dose with the as the pregnancy advances with the weight gain. And for the treatment, the therapeutic dose, the low molecular weight heparin is enoxaparin 1 milligram per kg subcutaneous every 12 hours, and deltaparin 100 unit per kg subcutaneous every 12 hours. So the unfractionated has to be given as IV infusion or as subcutaneous every 12 hours, but titrated with the APTT to keep it in the therapeutic range. Now, if you see the RCOG guidelines here, this part here, lower part, so it is said that they have in their guidelines, they have talked about the LMWH. So for a patient less than 50 kg, they advocate 20 milligram every day. 50 to 90 kg, you give 40 milligram enoxaparin or 5,000 units deltaparin. And 91 to 130 kg, it is 60 milligram. More than 130 kg, it is 80 milligram. And 170 to more kg, it becomes then per kg body weight. So this situation is very rare. But yesterday in our HTU, I found a patient of 140 kg to whom we had given 80 milligram of enoxaparin. So it is not unusual to have such cases. So when to start thromboprophylaxis after cesarean and its relationship with the neuroaxial blockade. So very important again, LMWH, if you are giving it in the prophylactic doses and you want to give it after cesarean in the prophylactic dose, you have to wait for at least 12 hours after stopping it, if it is being given in the antenatal period, and you have to wait for at least 12 hours after neuroaxial blockade, but 4 hours after catheter removal. So this is important. We don't need to wait endlessly. After catheter removal, you can give it after 4 hours. And if it is in the prophylactic dose, then the same goes to 24 hours. The waiting period after stopping, you have to wait for 24 hours. And then when you restart, you have to give 24 hours after the neuroaxial blockade. And after catheter removal, you have to wait for only 4 hours. And for the unfractionated, it is only a wait of 1 hour. So that is why I said if you have to give it fast after cesarean, you can give it, if of course we wait for 6 hours minimum, because we don't want our patient to have any hematomas or bleeding. But from the point of view of neuroaxial blockade, we have to wait for only 1 hour after the blockade and catheter removal before restarting the heparin. So this is very important to remember. And how long do you continue the prophylaxis? The duration of postpartum anticoagulation depends upon the underlying reason for the anticoagulation. For intermediate risk, we can give it 10 days as per RCOG, 6 weeks in the high risk. ACCP again says that you can give it only till the patient is hospitalized. And that is what many of us do, that for the low risk, the intermediate risk women, you may give it only till the patient is hospitalized. And for high risk, of course, it will be continued for 6 weeks in the postpartum period. So this one I am going to skip. And what about monitoring? So no monitoring is required with LMWH, except if there are extremes of it. So even if you are giving prophylactic doses or therapeutic doses, normally we don't do the monitoring of the anti-10A levels unless it is the extremes of weight, or you are giving it for indications like mechanical heart valve, where it is very important that the patient is, getting the right dose for thromboprophylaxis. So otherwise we don't do it. For the unfractionated heparin for prophylactic low doses, we don't need monitoring. But if you are giving it in the high risk women, so then you have to do the APTT and keep it between 1.2 to 2.5 times so that you get the adequate thromboprophylaxis. So this is about the monitoring. And quickly, I'll just tell you 2 cases which we have managed. I have just given you the key points of those cases. These are by chance the cases came up, and I thought it is very interesting to share with all of you here.
No, they're very interesting, but can we make them little brief, Dr. Jyotsna?
Yeah. So G2P1L1 admitted at 36 weeks. She came and she had history of DVT 2 years ago. So post-cesarean DVT she had, and patient took LMWH for 3 to 4 weeks and then stopped treatment in the last pregnancy. There was no follow-up. So now she came to us with this diagnosis that previous history of DVT in the last pregnancy. At 36 weeks she came. And when we did her lower limb Doppler, she still had the part of the clot had not yet resolved, even though more than 90% flow was there, but there was a hyperechoic thrombus still there in the femoral vein. So the dilemma was that how to manage her in the perioperative period. Should she be managed as a case of DVT? Which anticoagulant to be given at 36 weeks, LMWH or the UFH? And how to, switch over? And what about the post-op period, when to start and what to give? So anyway, what we did, I'll just tell you quickly that we started her with the UFH 10,000 units 12 hourly. We treated her as a case of thromboembolism and as a DVT, and then we shifted her to HTU. We started the IV heparin infusion at the rate of 18 units per kg per hour. Then, before 24 hours of planned cesarean, and infusion was stopped 6 hours before, and APTT was done till the APTT came to near normal. We did not do the cesarean, but after that, with a single short spine, which was uneventful. And later, after the cesarean, again, after 12 hours, the drip was started for her for 12 hours again, and then she was shifted to the LMWH. And later on, the warfarin was started. So this patient, very posed a big challenge for us. But anyway, now, since the time is short, I will not discuss about this particular study and other things. And this case too, G2P1L0 with previous preterm cesarean for FGR and severe PE at 34 weeks with high titers of ACL IgG was planned for elective cesarean at 38 weeks. She was on aspirin 150 during antenatal period. So how do we manage her anticoagulation? So she was a case of APLA. So here I just wanted to show this guideline that for APLA, if the patient had a previous delivery at 34 weeks or earlier for a morphologically normal fetus, so in the pregnancy, she can be treated with the low dose aspirin. But in the postpartum period, such a patient needs to be, if she had a cesarean delivery, she needs prophylactic LMWH for at least 6 weeks along with the aspirin. But if she had vaginal delivery, she would have just needed the intermittent pneumatic compression and the aspirin. So this was a case which we had managed, so I thought I'll share it. So the key points, of course, we have already told that cesarean section is a high risk period, and for women who undergo cesarean and have no additional risk factors for VT, early ambulation and hydration is suggested, and mechanical devices rather than pharmacological thromboprophylaxis in women with one moderate risk factor is recommended. For women who undergo cesarean and have additional risk factor for VT, both pharmacological and mechanical thromboprophylaxis is suggested. The most common drug which we use is the LMWH, And in some situations where long-term prophylaxis is required, warfarin may be used. Rivaroxaban is suitable in non-lactating women for long-term prophylaxis. And the duration of prophylaxis is mostly limited to the hospital stay / 10 days. And in high-risk condition, it is given up to 6 weeks post-cesarean. So thank you very much.
Thank you, Dr.
Thank-
Jyotsna. That was really nice, very exhaustive. I think we can have comments from the experts and
Congratulations, Dr. Jyotsna. You have beautifully described everything in detail about the thromboprophylaxis in after cesarean section. I must say that in our hospital that we are using a DVT scoring system also. That means in all the patients who are coming to the labor room, there is a form which is attached to the file, which tells us that what is the score of this thing, whether this patient is going to need the thromboprophylaxis or not. As such, that scoring is done. Suppose the score is more than 3. This is called Caprini score. And if the score is more than 3, then these patients are for thromboprophylaxis in the post-cesarean, post-delivery period also. And you have beautifully described all the risk factors which can be there. And secondly, that it's very important that during this thing, when the patients are in labor, then patients are dehydrated also. One should maintain the IV drip so that they are not dehydrated, because there's a very high risk factor to cause the thromboembolism. Then thirdly, that women with 2 or more persisting risk factors, asymptomatic or acquired thrombophilia, emergency cesarean or elective cesarean section with 1, 2 or 3 factors, that is age more than 35 or the BMI more than 35, should receive thromboprophylaxis. And what we do in our hospital, that during cesarean only, if the patient is in the high risk group, then on the cesarean table also, patient is given this thing, DVT pump or the pneumatic compression pumps. They are also applied. And you have rightly said that this thromboprophylaxis has to be started at least 12 hours after the procedure has been done. Thirdly, that is very important is that if surgery is lasting for a long time, that is more than 120 minutes, that is more than 2 hours, it is very important to give thromboprophylaxis to these patients. And you have rightly said that patients who are in the class 3 obesity or the BMI weight more than 40 kilos than VT in the last pregnancy, they should receive thromboprophylaxis, and that should continue for at least 7 to 10 days post-delivery. And thirdly, that patients who are already known case of thrombophilia and they're already on anticoagulants, they should also continue with thromboprophylaxis for at least 6 weeks post-delivery. And they can be switched over to, you've already said that they can be switched over to acetonol warfarin. That is after about 5 days of and then we can overlap with the LMWH also, and then we can continue. And I think you have beautifully described everything in detail.
Thank you, ma'am. Thank you so much.
Dr. Archana.
Thank you, ma'am. Thank you for inviting me. I think early ambulation and use of pneumatic compression device goes a long way in preventing VTE. So we should all concentrate on that. It should be given uniformly to all post-cesarean patients. I think that would help a lot. Thank you very much. And it's a beautiful talk by Dr. Jyotsna.
Thank you.
Thank you, Dr. Surekha. You want to add anything?
Dr. Jyotsna has covered everything. I have one question.
She's actually covered everything in detail. Yes.
One question to ask to Dr. Harsha Kullar.
Yes.
Ma'am, you said if the surgery lasts more than 2 hours, so you are talking about any obstetrics gynae surgery or cesarean only?
The cesarean, suppose there is adhesions and suppose you are also doing the myomectomy along with the cesarean. So those cases, if they are lasting for long.
Okay.
So in those cases, I think one should think of giving thromboprophylaxis in the postpartum period.
Yeah, because it becomes extensive surgery.
Right.
And I have one thing to add. What I am practicing since last 40 years, obstetrics when he was there. So what I have taught my staff is when the patient is shifted to the ward and after 4 hours, whenever they go to check the vitals, they have to move their foot, their
Legs.
left from knee, and they should make them take deep breaths by keeping hand on their abdomen, take deep breaths. Every time they go for checking their vitals, they have to do that, and everybody does that. Now we have started using pneumatic cuffs as well as, but this is the most economical and easy method to avoid DVT.
I just want to share with all of you that we had conducted a study in 2005 to 2008 on 500 patients. I think we were pioneers in Delhi to do this study. One of my students only, she did a study. She's working in now Max Hospital. And we had done this study on 500 patients, where 300 were high-risk patients and 200 were low-risk patients. And out of these 500, obstetric patients, low risk were 131 and 96 were high risk. And those days we were doing compression venous flow studies, and we found that there was much improvement in patients who were high risk in the post-delivery, where we started on that LMWH. And from 89%, and it improved to about 98%. So this was a study published also, and this was a study done in 2005.
Thank you so much, ma'am. Thank you, Dr. Jyotsna, ma'am, and all the experts.
I think I would just like to add one thing. It is difficult to remember all these things with so many things on mind, and the scoring and all that. I think every labor room, we should just put up one chart on
Yes,
on the
that is
board.
what I told you in the beginning. Only all the patients in our hospital, it's a must in all the surgical patients in delivery room also. All the files in the front, this in front page is that only. And all the students are supposed to do the scoring.
I'm saying in the labor ward,
Yes,
on
in the
wall,
labor
on
room
the
we should
board,
have.
you
Yes.
should have one. Okay, these are the patients you have to give heparin. No
Right.
explanation, just
Simple.
it shows so that it is implemented. Otherwise, we can keep reading and we keep forgetting.
Reva, ma'am, you want to add
This is
something?
in the NABH accreditation also. They have also said that there should be a captaincy score paper that should be attached with all the files. Recently, we had that.
Yeah, but that is very, very theoretical, Dr. Harsha. Attaching all these scores, practically nobody does it. If you put it on the wall and say, okay, these patients need, LMH, low molecular weight heparin, it will be implemented.
Yes, I think.
Right.
Can I just ask Dr. Jyotsna one question? Wonderful lecture, of course, Jyotsna, but the case that you presented, you talked about giving a heparin infusion. My question to you is, why infusion? Why not injection? Because what was the great urgency?
Ma'am, the reason was we treated her as a DVT because there was still the clot.
No, but that's an old clot. No, they don't resolve. We know that.
No, ma'am. That was there. So we had discussed it with our cardiothoracic and the other teams. So they said that in the cesarean period, now this patient is again at a very high risk of having a thrombus, because in last cesarean, just on the 4th day, she developed the thrombus. So we don't want to give her any opportunity to have that thrombus grow. Already there is a nidus there, so it can grow anytime. So that was the reason why. And why, ma'am, we gave the infusion was because we had to do a planned cesarean for her, and we did not want to leave her for a very long time without covering her with the anticoagulation. So if we would give her the subcutaneous, we would have had to stop it 24 hours before the planned cesarean.
12.
And yes, ma'am, because the
12 is good enough.
No, ma'am, for prophylactic it is 12 hours. But if we were giving 10,000 12 hourly, that was the therapeutic dose. So we were told to stop it 24 hours before the planned cesarean. So we did not want to give such a big window of time, leaving her without anticoagulation. And half-life of the unfractionated is only 1.5 hours. So with infusion, we can immediately reverse the action. That's why we did it. And anyway, patient did well, and luckily she got discharged. So
also, I think we use protamine too little.
Yes,
we can use protamine.
Protamine we should use. I know that is exactly something which we should be getting familiar with.
Thank you so much. I think Mancham, we move on.
Thank you. Moving on to the next session, which is to the need of the hour, ERAS, enhanced discovery after surgery and focusing on the cesarean. My slide is, So Dr. Sujata Agarwal, who is a senior consultant in Delhi, and our Cultural Secretary, Delhi Gynae Forum South. I welcome you, ma'am, for the talk. And the experts of the session are Dr. Sangeeta Gupta, who is a consultant at HOD Department of Obs and Gynae ASI Hospital, and Foxy Faculty for Maternal Mortality Workshops. We welcome you, ma'am. Dr. Renu Mishra, ma'am, herself. She needs no introduction, I think, again. And Dr. Meenakshi Ahuja, who is a Senior Director of Obs and Gynae at Fortis LAFM and a Senior Consultant, President, IMS Delhi. I welcome you, ma'am, and over to you, Dr. Sujata, please.
Thank you, Dr. Let me share my screen. Okay. Good evening, everyone. So after listening to exhaustive talks on antibiotic thromboembolism, let's move on a different topic, enhanced recovery after cesarean section. Slide change your. Okay. So this concept was first introduced in 1990 and later implemented first in 2005 by Netherlands. And the concept is, it is an evidence-based system to improve maternal outcome, functional recovery, maternal fetal bonding, and patient experience after cesarean section. This is shift from traditional pre-operative, post-operative care. Remember our aunties, they used to lie down straight for 3 days on IV fluids, nil orally, and then they discharge after 8 to 10 days of cesarean. But now everything has changed. It's a jet age. So the aim is to reduce the physical and psychological impact of surgery, reduce organ dysfunction, shorten hospital stay, facilitate rapid recovery, return to normal activity, and improve hospital experience. These days, after delivery patients, they feel so excited, red, pink balloon when girl, blue balloon when boy, and so many things. So just to make them happy. We divide this post-operative better recovery into 3 parts: pre-operative, intraoperative, and post-operative. This is a very exhaustive slide saying strong evidences, weak evidences. And I am going to sum them up in a much simpler way. So pre-operative counseling, always do counseling of couple, not only patient, both the couples. Try to correct all the diseases which are correctable, like anemia, thyroid, diabetes, asthma, and talk about complete complications, how we deal with them, what are the risk of complications, take a proper consent, and tell them about feeding, ambulation, ask them to stop smoking, what medicines we'll be giving them, and ask them to meet neonatologists, go to an ICU, and we'll tell them about pain relief, how that cesarean is not we are going to do everything so that they will not have any pain post-operatively. This reduces their anxiety. This is the most important concern. Now, pre-operative, always admit on the day of admission to give them less anxiety. It is recommended to give them clear fluid 2 hours prior to surgery. Don't keep them nil orally overnight or 6 hours. And before 6 hours, they can take a good carbohydrate loading drink or high energy drink. This will reduce peri and preoperative thirst, and it will also maintain insulin into normal range. So 2 hours before surgery, all liquids, clear liquids, and 6 hours before surgery, a good diet with rich in carbohydrate. Preoperatively, we should always give histamine receptor antagonist and MCIT to reduce risk of pulmonary aspiration pneumonitis. This is a strong evidence. Preoperative sedation should not be used before delivery. This is strong recommendation. And oral and mechanical bowel preparation should not be used. No enema anymore. This is also a strong recommendation. Now, regarding anesthesia, it is always better to use regional anesthesia. This is strong recommendation. And during anesthesia, hypothermia is very common in 50 to 80% of patients. So hypothermia correction is very important because it can cause neonatal temperature problems, umbilical pH problems, and FGAR problems. And to maintain this, we should use forced air warmers. We should use warm IV fluids and increase the temperature of AC in OT. So these all are strong recommendations we should follow to prevent hypothermia in all the patients. Now, antibiotic prophylaxis already covered. It should be given within 1 hour of surgery, and vaginal preparation is advised with iodine. I don't know, but there was some confusion, but iodine is always good. And for abdominal preparation, chlorhexidine alcohol is preferred to aqueous providine iodine solution for abdominal skin cleaning before cesarean delivery. Intraoperative, always transfer incisions are preferred, strong evidence. Use of nasogastric tubes, abdominal drains, vaginal packs is not recommended. This is strong evidence. Now, regarding cesarean technique, blunt expansion of transverse uterine segment with manual after giving a small incision, extension with fingers. This is recommended. This is a weak evidence, and everybody thinks this will cause less bleeding, better in recovery, but this is a weak evidence. 2-layer uterine closure is better than single-layer uterine closure because this will make residual myometrium thick. So to prevent uterine rupture, this is, although it's a weak evidence, but I think it's a good idea to suture uterus in 2 layers. And no strong evidence to support any particular suture material. We can use Vicryl, catgut, anything. And no strong evidence to support any particular needle, whether it is a sharp or blunt. So both can be used for cesarean closure. Now, abdominal wall closure, there is no strong evidence that outcomes such as intra-abdominal adhesions are less with closure of both peritoneums. In fact, closure of peritoneums can cause chronic pelvic pain, more bladder symptoms, and more recovery of bowels after surgery. So closure of peritoneum is a weak evidence. It is no strong evidence to support closure of rectus muscle in midline, because this can cause more operative time, delayed bowel recovery, and more post-operative pain. So we can leave the rectus muscle as such. The abdominal fascia is usually closed with a continuous suture, and non-absorbable suture material are better than absorbable suture materials. This is strong evidence. And women with more than 2 centimeters of subcutaneous fat, we should we approximate or not? So reapproximation of tissue should be performed. This is a weak evidence, but this makes healing better and less wound infections. And subcutaneous closure with a suture was supported for the reduction of wound complication as compared to interrupted sutures and staplers. Now, blood volume management is very important. Preoperative and intraoperative volumes are important factors in patient perioperative care and appears to lead to improved maternal and neonatal outcome after cesarean delivery. This is strong evidence. So please keep an eye over fluids, that patient should not be dehydrated. Now, neonatal care regarding cord clamping in cesarean, 1 minute wait for a term fetus and half after 30 seconds clamping in preterm fetus is recommended. And body temperature should be maintained between 36.5 to 37.5 after birth. And routine suction of airways is not recommended if airways if there is no obstruction, because it can cause trauma and it can cause infection. And in all settings of cesarean, we should have a proper neonatologist and a resuscitation facility. Now, guidelines for post-operative care. So passive chewing gums and smell of food, sham post-operative feeding, this all improves bowel movements and patient feels better. Early diet can be given to such patients, so it is recommended. Fluid overload and intravenous administration of ephedrine, phenylephrine, which we are not using, but in Western countries, they might be using it, and lower limb compression are effective in reduction of hypotension and evidence of incidence of intraoperative and postoperative nausea and vomiting. So good fluid management can cause decreased nausea and vomiting. This is strong recommendation. Antiemetics can be given for prevention of postoperative nausea and vomiting. This is good evidence, a good recommendation. A regular diet can be started within 2 hours after cesarean delivery, and we must give a clear instruction to our nursing staff. Then don't keep patient nil orally or fasting for a long time. Many times we do cesarean morning and coming back for rounds in evening. Meanwhile, the patient is lying straight without anything. So this should not be there. We can start a diet within 2 hours. And good control of blood sugar in diabetes is very important. As ma'am has already discussed, pneumatic compression stockings are used to prevent thromboembolism in general patients, and heparin should not be used routinely in all the patients, only in patients who need prophylaxis against thromboembolism. And we should promote breastfeeding and maternal bonding as early as we can. We should bring neonates as early as can in the bedside. Now, post-operative pain management is very important. It should be prevented and treated proactively. The aim is to prevent addiction with any kind of opiates. So it's better to use non-opiates and NSAID orally. Spinal, epidural, renal blocks can be top up after surgery to give pain relief. And regional blocks in case of general anesthesia, like truncal blocks, wound infusion with local anesthetic, or wound infiltration with Jalokin, or transverse abdominis plain block can be given if patient has underwent general anesthesia. So catheter, ideally we should remove catheter soon after cesarean. This is a good evidence. Leaving catheter will give rise to UTI. And it is the catheter is required in case we need strict input-output watch patient with kidney disease and cardiac problem or patient with PET, but otherwise we should remove catheter as soon as we can. And this can lead to, it will not, putting catheter will not help in reducing post-operative urinary retention. Agar hona hai retention, then patient will have. Now, this is a study which shows 707 major gynae procedures done in 5 years, and they discharged all these patients following these criteria within 2 to 3 days. And out of these 700 patients, they were very happy. Only 7 patients has post-operative paralytic illness, and when 1 patient had nausea. So this is a very good protocol to follow in patient of cesarean section. Discharge should be done when patient has passed flutters. She's eating, drinking, pain is controlled with oral antibiotics, and we can prescribe her later some stool softener, but never give anesthesia, enema before surgery. And patient can be recatheterized if required, and she can go home with catheter if she has developed retention. We should give proper contact number of doctor and emergency services in case required. And these are few publications, very recent, within 3 days. This is the same protocol adopted in Bangladesh. And another one, this was published in Anesthesia Journal regarding implementation of ERAC. Standardized care will likely to improve patients and low addiction rate. Basically, they were more worried about addiction of opioids. This is another publication. So these are just to show you that in Western society, they are following a fixed protocol and try to make patients more friendly so that they can go home and they can enjoy their cesarean also. So preoperative care should be there, intraoperative, postoperative, and this all will make patient life easy and she can go home. So to sum up, reduce hospital stay, it can be reduced by 30% by using ERAs, reduce chronic pelvic pain post 1 year of cesarean by using those non-suturing of visceral and peritoneum and rectus muscle. Early feeding and ambulation restores feeling of well-being rapidly, reduce post-operative complication by 50%. And there is no increase in readmission, increased satisfaction rate, and improves hospital experience. So thank you so much.
Thank you so much, ma'am. That was really nice and informative. I would request the experts to give their opinion, please. Dr. Renu Mishra, ma'am.
Sangeeta, you're muted.
Dr. Sangeeta, ma'am.
No, she's muted. Dr. Sangeeta, we can't hear you.
1 second, I will unmute.
Thanks, Dr. Sujata, for such a quick and descriptive description of the IRAC, that is enhanced recovery after cesarean. And she has discussed in detail of all the evidence-based recommendations in pre-operative, intraoperative, and post-operative period. As we all know that cesarean rate in India is increasing dramatically, and not only in the private hospitals, but in government hospitals also. So I would focus something for the government hospital, that how to enhance this recovery in government hospital where we are having bed problems. There is doubling. In a single bed, there are 2 mothers, 2 babies. So I think the first thing is for the elective patients in a government hospital, they should be very well counseled. Their hemoglobin level should be up to the mark. Their morbidity should be taken care. Pre-operative high-risk cases, morbidity has to be taken care. They have to be properly counseled about the preparation of surgery. They should not come full stomach to the hospital. So all these factors have to be taken into account, and very important aspect in a government hospital is that when we are ready to discharge the patient, but from pediatrics point of view, patient is not fit for discharge or no discharge is available. So even mother being discharged, being a comfortable position, the baby is not in a condition to discharge, and if we discharge the baby early, the number of follow-ups to the hospital increases. So I think taking this points which cover all the preoperative, intraoperative, and postoperative recommendations, which are the processes. And if we really study these processes, implement these processes, audit these processes, evaluate these processes, and optimize these processes, these are really going to help in enhancing the early recovery of cesarean. And thanks a lot for giving me this opportunity to put my views in front of all of you.
Thank you, Dr. Sangeeta. So we all know that we've come a long way in how we manage surgical patients, cesarean or other surgical patients. It's, no like weeks of lying down and fasting. So the two main points which have been focused in ERAS, which is a protocol which starts from the preoperative preparation to intraoperative, postoperative, are that patients should not be kept fasting too long. Because preoperative, if she is fasted too long, then her insulin levels rise, and which actually increases her analgesic requirement intraop and postop. That's been shown. So only now they say 2 or 3 hours fasting for clear fluids, but of course 6 hours for solids. That still has to remain 6 hours. And postoperatively, you can actually start giving them clear fluids even in the immediate post-op recovery. If patient is awake, like cesareans are usually in spinal, we don't do in GA, but if patient is obviously awake in spinal, you can start giving them clear fluids even immediately if the patient asks. So the two main things are early feeding and early ambulation. And now, of course, this ERAS protocols, when you read different guidelines and recommendations, there are a lot of recommendations of it. There's an ERAS society now. So they say that you don't have to wait for flatus and bowel movement. And believe me, this has come in writing now. My husband told me 15 years ago, he's a surgeon, you don't have to look for bowel sounds. Put a hand on patient's abdomen. If the abdomen is soft, she doesn't have tachycardia, feed her. And believe me, I have done this since 15 years. I have never heard bowel sounds in a post-operative patient, unless she had a problem, gynae patient, not obstetric. And I have not regretted. In fact, I tell residents, please don't look for bowel sounds. I keep telling all of them, I don't know how many listen to me. And you don't have to wait for flatus. If you give them something to eat, they will pass flatus. So you don't have to look for flatus at all. That is a very, very obsolete, recommendation. I mean, if you're doing bowel surgery, I understand. You look for bowel sounds, But the interesting part is that this ERAS started in 1990s in Denmark on colorectal surgery patients, where there were anastomosis. And in these patients, they started giving fluids in 2 hours. Some people started feeding in 4 to 6 hours. In patients who had an anastomosis, they were fed, and they did not find that there was any problem. In fact, they found that the analgesia requirement post-operative was less, and patients went home early. And the earliest studies showed that the patients after colorectal surgery who remained for 3 to 4 weeks could be discharged in 4 to 5 days. So that was a real change in post-operative management. And I think in cesarean, of course, we have to individualize patients, but generally these are young, fit, healthy women who are ready to eat. And actually, it gives you a feeling of well-being when you eat. When you're fasting and you have pain, so do cheezein hai which hit you. One is you're hungry, and the other is your pain. And the pain becomes worse, actually. So thank you.
Thank you, ma'am. Dr. Meenakshi, ma'am.
Thank you, Pancham. I think Dr. Sujata did a very great job because she took it so well, stepwise, very easy steps. And we all feel that these are some things that we should have been incorporating in our practice, and if we haven't, they're very easy to incorporate. I think Dr. Renu covered the other steps, which were, probably the lacunae which were there, maybe the few lacunae which were there. I just want to make one little point, because I think in our patients, psychology plays a very, very strong role. And the minute they have a cesarean, they feel that it's the end of the world, ki hum to normally chahte the. What I've seen in my practice is that patients who, have a cesarean by maternal request, they really recover fast, because I also explain to them that you must recover fast because you have a point to prove to everyone else that taking this decision was not a bad thing. And otherwise, the minute you are going to be lazy and not move about and all, the first thing everyone is going to say, देखा हमने तो कहा था कि normal better होती है. So you actually see those patients recovering faster, and patients who are hell-bent on normal delivery, if they end up with a cesarean, they will always take that, the longest time to recover. So probably in an antenatal period, explaining to them that whatever is going to happen, even I'm not sure what's going to happen. The point of doing all this effort that you're putting in, whether it is your diet, whether it's your exercise, whether it's correction of anemia, whether it's thyroid, even the yoga classes and all that you're doing, the aim is not normal delivery. The aim is to have an easy delivery, whether it is by normal delivery or by C-sec, and that your recovery should be good. At the end of the day, the reason why you're looking for a normal delivery is so that you have good recovery. And if we can give the same recovery by C-sec and you are mentally prepared and physically prepared for it, I think those patients really recover faster. So of course, all these steps need to be taken. But, telling patients, I guarantee karti hu normal delivery hogi and all that, you must explain to them at the same time that if you do have a C-sec, it's not the end of the world. After delivery, like Dr. Renu clearly said, that you can start early feeding. There is no difference in the postpartum period, whether you have a normal or C-sec, and 40 days later, you can go back to exercises, considering that we still, people believe that that incision that we used to give earlier, which none of us give now, we all give pen and steel. Recovery is so good and fast. So you have to explain to the patient that later your exercise routine and everything is going to be the same. Getting up is not going to be a problem. Probably a lot of counseling also alongside will help in early recovery. So that's just a point I wanted to make.
Exactly. It is a multidisciplinary team, like it is an obstetrician, a counselor, and anesthetist and pediatrician. Means anesthetist has to say that the type of anesthesia is that the pain, post-operative pain is less, use of opioids is less. Pediatrician has to say that baby is fed, early breastfeeding lessons are given in proper time, so there is no delay in learning the patient that how to breastfeed the child. So
absolutely, breastfeeding has to be encouraged from the first day.
So this all things have to be combined together and taken into practice so that there is a early recovery of and enhanced recovery of the patient.
This is a very interesting observation, which Meenakshi said. I have never observed actually that patients who want to have a normal delivery and they end up in cesarean, their recovery is slower. That's a very interesting observation.
Dr. Eva? It's all in state of mind.
Is it, Dr. Eva, what is your experience? I don't deliver that many now, so.
I'm not sure, because they are generally disappointed because they haven't been able to have a virile delivery. I'm not sure whether that translates into more pain and other things. Maybe it's just an individual psychological response.
Yeah, probably. That's what I said. The recovery is slow because their mind is not into that. They are disappointed with the whole process.
I think things are changing in the newer this thing. Now there are lots of cesarean delivery, so they are more prepared.
After the C-sec, I'll tell them even with normal delivery, you would have had stitches.
Actually, that's a good area for doing a study. Honestly,
definitely. Yeah, I think we can.
There's a question in the chat box. How soon can abdominal exercises be recommended post-cesarean? Dr. Sujata, you would like to answer that?
Dr. Meenakshi just mentioned 6 weeks after cesarean. I think you can walk,
yes,
jog,
absolutely.
and you
they
can
can
do
go
all
back.
exercises.
So normally I tell my patients that, whatever exercise in the postnatal period, the physio has told you to do them for 40 days, including your Kegels and everything else. But 40 days later, please go back to your walks. Start your yoga within 2 months. Within 3 months, you should be doing everything except heavy weight lifting. That is, if you used to lift up 50 kg of weight, you are lifting up the baby. So anything till 6 months, which is the baby's weight, is absolutely fine to lift, which is what, add that sentence always, which is what I would have told you if you had a normal delivery anyway.
Yes, I think
that sentence always.
Yeah, but I start telling at 2 weeks, my patients, if you're not having pain, then you can start doing little leg raises. Not full-fledged exercise, but that, of course, 6 weeks.
Cycling.
So I don't think there is anything more in the chat box.
There are no more questions. There was one question, Cetavilon, can we use diluted or undiluted? Dr. Jyotsna answered it as we don't need to dilute that.
Okay.
So there are no more questions coming on to the end of the session. I would like to thank everyone, Dr. Shadajan ma'am, for enlightening us, all the speakers for the day, Dr. Renu Mishra ma'am for being the mastermind after this, and all the experts for sharing their expertise and opinion and their experience with us. There's a saying, one book, one pen, one child, and one teacher can change the world. There were so many teachers today. I think the delegates and us too, we must have learned so much today. Thank you so much, everyone.
A very enjoyable CME, because this is something which affects our daily bread and butter, you know. And
Dr. Renu, whatever you enjoy, arrange is always enjoyable. I know the labor you started doing in way back in 6-7 years back, that delivery of second stage and all that, it's all really very practical and very enjoyable.
Thank you so much. Thank you all for sparing time. I know time is valuable with so many webinars, so many activities nowadays. So thank you all, the faculty, experts, everybody for sparing time for us. And we don't want...
Shield Connect too.
Sorry?
Stop sharing.
Shield Connect too for giving us the platform for the session.
Yeah.
Stop sharing your screen, please.